Understanding Medicine.
I'm Professor Aziz Rehman, and today we're going to talk about urinary tract infection. It is a fairly common infection. I think the commonest infection in humans is respiratory tract infection. After that, gastrointestinal infections, skin infections, and urinary tract infections are common. Although there are some specific predisposing factors, some specific factor which can complicate infection, but actually urinary tract infection is possible in any individual. What is it? And let me explain. So this is basically urinary tract. It consists of a renal pelvis, the ureter, and the bladder, and then the urethra. And in men it also includes prostate, and then of course attached structure like seminal vesicles. In women, although vagina and the uterus and the fallopian tubes are separate structure, but there may be sometime involvement of those structure in infection also. So primarily a urinary tract infection refers to infection of any of the part of the urinary tract, mostly just the urinary bladder. Then it would be called cystitis, or it may actually extend upward, and then it was called pyelonephritis. It could go into the renal parenchyma, and in some bad cases it could go outside the kidneys also. It could turn a kidney into an abscess or a pocket full of pus cells, but mostly it stays within the urinary tract. And usually, since there is a constant formation of urine, and you really have to have some predisposing factor to have the infection established, because mostly bacteria, those bacteria which ascend from the urethra, they actually are washed out again. So the infection is not as common, although there is direct opening to the exterior. Prevalence infection is much commoner in women as compared to men, except in small children. In small children, the prevalence may be the same, and in elderly also, because of prostate enlargement. In men also infection becomes common, but in young women infection is much more commoner than men in the same age. And this is because of several reasons. One, women have much smaller urethra, although we have urethral sphincters, but in men a long urethra helps to prevent infection. In women, urethra is small, so I think bacteria find it easy to ascend the urethral tract. Plus in women, that area, the perineal area, the vulvar area, that is mostly moist, and there is usually bacterial growth in that part, and that easily find access to the urethra. Then sexual intercourses, the frequency of intercourses, and also the number of partners, that also increases the prevalence of infection in women. And internal tampons, many women, they use this as their personal hygiene, so that could also be a source of infection. But the fact remains that urinary tract infection is much commoner in women as compared to men. Of course, men can also get it. So our reflex is that if a woman comes with urinary tract infection, we normally treat it like any infection. But if the infection occurs in men, then we usually ask ourselves why this happened. So in women, just being a woman is good enough reason to have infection, but in men there has to be another reason, especially if the infection is recurrent. Now, there are two terms. One is urinary tract infection, which we are going to talk about in detail. That is actually true infection. That is, bacteria have invaded the urinary tract and that has caused infection. And infection usually means there is uh, attraction of neutrophils, presence of pus cells, and inflammation in the urinary tract. As compared to another condition, there may be asymptomatic colonization of bacteria. So asymptomatic bacterial colonization, this is actually an asymptomatic condition. It is extremely important not to treat these patients because they do not have infection. Especially in women, it is possible to isolate microorganisms from the urine, either on routine microscopy or on culture. So my lesson is, if you have somebody, man or a woman, who does not have any symptoms of urinary tract infection, who does not have pus cells, please ignore presence of bacteria, whether they are isolated on microscopy or on culture. So treating them with antibiotic would be unnecessary, exposing them to the bad effects of antibiotics. Then types of urinary tract infection based on site of infection and time frame. Now, based on site of infection, since bacteria ascend from the pelvis, so I think the first thing would be cystitis. Most patients would be diagnosed at the level of cystitis. Before it gets complicated, symptoms would suggest the diagnosis, and a simple short course of antibiotic would relieve the symptoms. Then pyelonephritis, if there is involvement of renal pelvis, that would be called pyelonephritis. Of course, ureter will also be a factor. So the infection is now in the bladder, in the ureters, and also the urinary pelvis. And the urethritis is a symptom, is a condition where there is involvement of urethritis, mostly in men, but also in women. And this is typically a sexually transmitted disease because patient is already very aware after having unprotected sexual intercourse. So any urethral symptoms after that event, I think, would suggest urethritis. Prostatitis. Prostatitis is a very complex infection and it could be a complication of urinary tract infection, or it may be infection in its own, or it will be complication of STD. But prostatitis is an infection which is very difficult to eradicate because the bacteria, they enter into the small and narrow and deep canals, the structure of the prostate, and usually a long-term antibiotic therapy like 12 weeks antibiotic is required. And this of course will occur only in men. Pelvic inflammatory disease, it is again a separate infection, but sometimes untreated urinary tract infection could lead on to pelvic inflammation. That means involvement of fallopian tube, involvement of the pelvis, and things become more complicated. Now, according to the time frame, infection can be classified into acute. That of course acute means that just few days illness, and it will be chronic. Sometimes patient has symptoms which never go. They're chronic for weeks and months. There is symptoms of dysuria, and also if you do examination of urine, you find pus cells. And then another, I think, very important condition is called recurrent infection. There are some people, especially women, and also men with some predisposing factor, they have this recurrent infection. And recurrent infection has got two concepts. One is that once you treat infection, within weeks, 1 or 2 or 3 weeks, it recurs. That is probably that the first infection was never eradicated. So it is actually relapse of the same infection. But it could also be another infection. Somebody has a predisposing factor like a stone in the urinary tract. That person can have infection again and again. So our approach to these patients is slightly different. Acute infection, chronic recurrent infections, they have slightly different treatment approaches. Now, etiology, the commonest microorganism responsible for urinary tract infection is E. coli. Now, I think before that, let me say that urinary tract infection is almost always bacterial. So I'm not sure if there is any parasites which can cause urinary tract infection or viruses which can cause urinary tract infection. So urinary tract infection is almost invariably bacterial, and out of bacteria E. coli. Since E. coli is our normal gut commensal and it is passed through stool, and the anal area, perineal area is normally contaminated with E. coli. So E. coli could easily ascend into the urethra and cause infection. In some cases, especially those who have stone, those who have urolithiasis, they are particularly prone to have Pseudomonas infection. Now, Pseudomonas infection, Pseudomonas are notorious to be very, very resistant to bacteria, to antibiotics. Sorry, the Pseudomonas are very resistant to antibiotics. So, if there is any reason to believe that the person has infection with Pseudomonas, you should never try empirical therapy. Go for culture, find the right antibiotic, used for the right duration in the right dosage. Chlamydial, typically a post-coital or sexually acquired infection, so that is also possible. Usually urethritis. Tuberculosis. Now, if there is a chronic infection that never goes, I think you need to consider tuberculosis also as the cause of urinary tract infection. Now, you would need a test, and I think you need to do AFB, you need to have maybe gene expert TB test or other tests, but TB is definitely not very rare in our country. It could affect urinary tract also. Candida albicans, people with very poor personal hygiene, particularly diabetic patients, particularly women with some abnormality with their urinary tract, like incontinence or cystoceles, they have this candida infection. Now, this patient would have symptoms of urinary tract infection, would have pus cells also, and culture may be negative, but urinary examination you will find candida. Said that it is also possible to find candida albicans in women or men who do not actually have infection. So if somebody does not have any symptoms of infection and somebody does not have any pus cell in the urine and routine urine examination shows candida albicans in women, I think that can be ignored. So culture negative UTI. Although, as I said, infection is always caused by bacteria, but it could very well be negative on culture. So negative culture could mean many things. Number one, it could mean that patient is already on antibiotic. It could mean that patient has got some infection which is not normal bacteria, like it could be candida or tuberculosis. Or it could also mean that bacteria are truly resistant to all antibiotics and they are very, very demanding in their culture requirements. So that's why they do not grow. So it is possible if somebody has symptoms, somebody has presence of pus cells in the urine, then negative culture I think does not rule out infection. I think the best practice would be not to treat and repeat culture at least 2 or 3 times until you find the organism. Now, organism based on a response to antibiotic. Normally, we expect that when we give antibiotic, there is prompt response, but that does not always happen. So, the types of bacteria, one is wild type. If you have wild type E. coli infection, we know what antibiotics usually work on E. coli. So, with the standard course of antibiotic, we would expect complete normalization of infection. So that is the wild type infection, the typical, the common type. But then we have multiple drug resistant strains. This can occur in any infection, in tuberculosis, in typhoid, and also in urinary tract infection. So there is infection, but those antibiotics where we normally feel very confident, like ciprofloxacin, but these people may not respond to those antibiotics. So I think culture becomes important. Sometimes the antibiotic, which is otherwise not known to be very effective, like sulfur drugs or amoxicillin, and these drugs may be actually, these germs may be sensitive to those, but not to ciprofloxacin. Extended drug resistance, and it is also possible sometime to find some organism which is not sensitive to any drug tested. Now the problem is actually when we send urine culture, there is no rule that which laboratory will use which antibiotics to test the sensitivity. Sometime I see the report where the urine is not tested for ciprofloxacin, for example, or some other antibiotics like. So it is many times it is possible to see the culture sensitivity report that the antibiotics listed, none of them is found to be effective. So in that case, I think you could either repeat the urine culture from another laboratory, or you could use a truly pan-spectrum antibiotic, usually in the form of combination. This XGR occurs in those patients who have half-hearted, inadequate treatment courses, and their bacteria become resistant. There are some predisposing factors. As I said earlier, anybody can have infection, particularly women, but then there are some factors which can increase the chances of developing infection. Female gender, I already talked about, frequency of intercourses and multiple sex partners, urolithiasis, particularly in both genders, but when somebody has a recurrent infection or the infection that never goes, or somebody has infection with some additional symptoms like pain in the renal area, so we should suspect urolithiasis. Presence of stone in the urinary tract definitely predispose to recurrent infection. Not only that, it also predisposes to some abnormal organism like Pseudomonas and resistant microorganism. So in these cases, of course, the initial treatment would be that of infection, but if this thing comes again and again, then you will have to do something for the stones also. BPH, that is benign prostate hyperplasia, which is almost all men they get with time, 60 or above. I think some people have seen after 50 they develop this enlargement of prostate. That would cause obstruction to the urinary flow, so there would be stasis, and stasis of fluid anywhere in the body promote infection. So these people are also more prone to get infection. Urethral stricture, this can happen in men, or it can also happen in women. So if somebody has recurrent urinary tract infections, please ask about the symptoms of urethral stricture. For example, if there is any difficulty passing urine, what is the size of the stream? Is there any dribbling? What is the feeling after you pass the urine? Normally there should be symptom, the feeling of complete relief after passing urine, but some people, they might actually not get that feeling. And if you're not sure, you could just sometime go for tests like ultrasound examination of the bladder before and after passing urine could tell if there is any retention. So a retention would suggest presence of stricture. And of course, the definitive diagnosis would require ureterogram and maybe cystogram. Vesico-ureteral reflux, this occurs in children, and normally the mechanism is when we micturate, the bladder contracts, the pressure builds up. At that time, the valves of the ureter emptying into the urinary bladder, they actually close. They close because they pass through the bladder wall in a way that once this pressure builds up, they get collapsed. But in some people, this may be ineffective. This mechanism may not be working fine. So Bacteria which could be normally present in the urinary bladder, they could go back to the ureters and then can cause urinary tract infection repeatedly. This is particularly common in children. If this thing happens, then we have to do the investigation. One is the radionuclide scan, and that can tell if there is a vesico-uretary reflux. This could get better with time, or sometimes it has to be repaired surgically. Indwelling catheter, elderly people with stroke or traumas, they have to have this indwelling catheter that can also promote recurrent or chronic infection. So infection can occur in anyone, but these are the factors which can increase the chances. And one more thing is diabetes. Diabetes, because of several reasons. Number one, diabetic patient, they are otherwise immunocompromised to a certain extent. And number two, urine has got glucose in it that attracts bacteria. And number three, some drugs, SGLT2 inhibitors we use, and that further increase the glucose contents in the urine. So that is further factor to attract infection. Not only urinary tract infections are commoner in diabetic patient, particularly uncontrolled diabetic patient, but they also tend to be more severe. They tend to be more systemic, and they tend to be affect kidney and cause some damage to the kidney also. Clinical features. I think urinary tract infection is a relatively easy condition to diagnose. Patient would give you the symptom of dysuria, that is some kind of discomfort, burning or other discomfort while they pass urine. Sometimes the discomfort may be very severe, like severe burning, or sometimes it may be just little discomfort. And also this discomfort in the suprapubic region after the urine is passed. And in women, there could be symptom of dyspareunia also. That means they feel some discomfort during intercourse. There may be frequency of micturition because they pass urine in small quantity but more frequently. And when it becomes extreme, it is called strangury. That means patient cannot empty the bladder completely. After passing urine and coming back, immediately within minutes, patient feels like going to the washroom again. And this is typically seen when there is a stone stuck in the urinary tract, and that is actually causing the symptom of strangury. Then fever with rigors and chill. Of course, any infection could become systemic, because as long as bacteria are present within the urinary tract, you would only have dysuria. But once they go to the bloodstream and then become systemic, so any bacteremic state would cause this rigors and chills. I think because some young doctors, they take rigors and chills with fever as symptom of malaria. That is definitely true, but urinary tract infection can also be characterized by rigors and chills. Then in severe cases, there could be hypotension, because once they become systemic, it could be actually endotoxic shock, and the things may become very, very serious. Luckily, this thing does not happen commonly, but those who are otherwise immunocompromised, bedridden with multiple comorbidities, elderly, they definitely are at a risk of going into the shock. So urinary tract infection should not be taken lightly. So diagnosis, of course, the symptoms of dysuria and burning, micturition and fever, and then presence of pus cell. I would like to emphasize that diagnosis of urinary tract infection is made on the presence of pus cells. Pus cells are neutrophils, because only presence of neutrophils, only presence of pus cells actually indicate infection. Presence of bacteria is not enough to make a diagnosis. So, and normally few pus cells, the few white cells, the leukocytes, may be present. Up to 5 may be present in a normal person, but for infection you need more than 5 for the diagnosis. Now you would see the reports like it could say 10 to 20 per high power field, or it could say numerous, or it could say field full of pus cells. So any term could be used. So I think they should be more than 5 per high power field. Now I have seen written it here, in the absence of frank hematuria. If somebody has like stone in the urinary tract and is passing blood, so that blood would also have white cells. So if you just count white cell, the person who has this actually hematuria, that person will also qualify for having more than 5 pus cells. But if there are too many red cells, if there is too much blood, then it should be viewed as hematuria, indicative of some other problem like urinary bladder cancer or some stone. So I think this is very important. Presence of neutrophils, pus cells, in the absence of red cells also. A red cell can be a complication of urinary tract infection, but in that case there will be only few red cells. Then there's a test called leukocyte elastase. Now this is an enzyme which is produced by leukocytes. So this actually indirectly indicates the presence of white cell. What is the difference? The difference is, for white cells you need microscopy, and for microscopy you need a human, at least so far. Of course, with artificial intelligence developing, you might see pus cell even without involvement of human. But leukocyte esterase can be tested with the dipstick. So if somebody is prone to get recurrent infection, that person can test his or her urine with dipstick and can find if there is infection. So presence of leukocyte elastase is an indication of infection. In people with infection, we expect pus cells to be more than 5 and leukocyte elastase positive. But I've seen people where there is disconcordance. One is present, the other is not. So I'm not sure how to interpret that report. Then I go by individual cases. In the absence of symptoms, presence of leukocyte elastase I ignore. But with symptoms, if any of the two are present, I treat it as urinary tract infection. Ultrasonography, particularly focusing on kidney, urinary bladder, may be helpful to unveil to show the underlying cause, if there is any, like BPH or stone. So that is important. And CTKUB. Sometimes we suspect stone as underlying cause, but that is not seen on ultrasonography. CTKUB is definitely a better test. So of course, these two would not be needed in all patients with infection, but I think urine complete examination, especially for the pus cell, must be done. And I have seen people who go straight for the culture, and not the doctor, the patient himself would go for the urinary culture if they have symptom without having the urine complete examination. I guess that is not a good approach. So you need to have first urine examination and then culture. You could have both together, but diagnosis of infection is made on the presence of pus cell, not on the presence of bacteria alone. So importance and limitation of urine culture. Applicable only after establishing infection. So first there has to be symptom and have to be pus cells present in the urinary tract or elastase present, and then I think culture would become relevant. If there is infection symptom and if the previous history suggests that this patient may have XDR or MDR, you could go for urine complete examination and urine culture simultaneously, but start treating only once you have the report. Proper technique of collecting sample, it particularly in women, because this perineal area has got normal bacteria. So I don't think there is anybody who would have no bacteria on this region, men and women, particularly women. So you need to have proper technique. The proper technique is, I think first the patient should be instructed to wash the parts with simple plain water. Then patient passes urine and collect and let the urine flow into the toilet, say, and then midway in the midstream collect some urine for culture, and it should of course be collected in sterilized bottle. Then send urine for culture sensitivity, not necessary in all, before you start antibiotic. If the symptoms are severe, you could just send the urine for culture sensitivity and start antibiotic empirically. But do send urine for culture before you give the first dose of antibiotic if you want to draw some reasonable conclusion from urine culture report. Or if somebody has already started antibiotic but is not responding. If somebody has started antibiotic and is responding, then you probably will continue the antibiotic. Otherwise, you will give a break of 72 hours. It takes about 72 hours or longer for antibiotics to be cleared off. Only then the culture will become positive. Otherwise, this antibiotic, it may be present in low concentration in the urinary tract, but it would not allow culture to be positive. And then negative culture do not rule out infection. This point is very important. In the presence of symptoms and pus cell, and negative cultures do not rule out infection. It could be some atypical organism like Mycobacterium tuberculosis or Candida or Pseudomonas, or it may be some normal E. coli, but they have acquired some special culture requirement and they are not grown on the culture. So in that case, you would probably do repeat cultures and then special culture. Most patients with urinary tract infections are treated empirically. That means we know that which antibiotic is going to be effective. Norfloxacin, for example, is very, very effective. It is a fluoroquinolone. It gets concentrated in the urinary tract. It might not have systemic antibacterial action, but it is concentrated in the urinary tract and is very safe and cheap option, 400 milligram twice a day. Nitrofurantoin is also an old-fashioned fluoroquinolone because it has not been in use for many years and it is still effective. So 100 milligram 3 times a day would be another option. Ciprofloxacin belongs to the same family, but this is more advanced and it has got some systemic actions also. Ciprofloxacin 500 milligram twice a day orally can be given, and sometimes amoxiclav, this simple amoxicillin with clavulanic acid, 625 milligram 3 times a day. These are safe, convenient options if you just want to go for empirical therapy, so they work in most patients. But be sure that you use the right dose and the right duration. The right duration is minimum 5 days. Also, as I always say, if the symptoms have completely gone and repeat urine test has negative, no pus cell, then you can discontinue. Otherwise, extend antibiotic course up to 10 days. So, culture-based treatment. First of all, I think before that, there is culture-based treatment means that if you do not, if you have the access to culture, then based on what we find on culture report, we give antibiotic, and it could be any of these or something that is not listed here. These are the common ones. Amikacin, which is aminoglycoside, 500 milligram, usually given intravenously twice daily. Tazobactam, which is a combination of penicillin and something which inhibit this enzyme which produces beta-lactamases. So I think that is typically in 4.5 gram intravenously, 8 to 6 hourly. Meropenem, a very good antibiotics, again from penicillin family, 1 gram 3 times, or ertapenem, which is 1 to 2 gram once a day. And what should be the duration? Typically we give 5 days, But I think it is best to have urine complete examination or urine for pus cell on day 5. If pus cells have completely disappeared or have come below 5, maybe it is safe to discontinue antibiotic. Otherwise, please continue for up to 10 days and do the same after 10 days. Sometimes urinary tract infection may require antibiotic for more than 5 days. So best way to go would be to have urine examination on the last day of antibiotic, and if there are no pus cells, then that means treatment has been the infection has been treated successfully. Some refractory cases, there are some cases who just won't respond to antibiotics, and these are some of the possibilities. They may be suffering from truly XDR. They have infection with the germs which are truly resistant to almost all antibiotics. They may be compliance issue in medical practice. Whenever somebody is not responding to any treatment, first thing we consider is adherence. And pyonephrosis, that means there may be abscess formation. Let me explain this. For example, somebody has got an abscess formation in right kidney. So that kidney will continue to excrete pus cells and bacteria, whereas antibiotic, whichever antibiotic you're using, is being concentrated by the other kidney which is functioning. So this kidney, the right kidney in this case, right kidney is pocket of pus not excreting antibiotic into the urinary tract. So antibiotics are not reaching there and not working, and the other kidney is excreting. So that is why there is no response. So I think in that case probably you will have to do the nephrectomy. The part of this infected bad kidney have to be removed. It could be tuberculosis. For that you will have to have test for tuberculosis, culture and MTB, DNA, PCR and gene expert test, and Candida test also. Candida infection, particularly in diabetic women, would end up people with HIV infection would require treatment with antibiotic against this Candida. Prophylactic treatment in some cases, particularly after unprotected intercourse with some other person, I think it would be advisable to take a dose of ceftriaxone 500 milligram, just one single dose intravenous, or ciprofloxacin just 100 milligram oral. So these can protect, but they will work only if you take immediately after unprotected coitus and before the symptoms develop. Some supportive treatment, urinary tract infection, people, the main treatment I have already discussed, but they would require some additional things or may benefit from some additional things like ample fluid intake, so that urinary tract is constantly washed and some bacteria are actually pushed out of the urinary tract. Alkalizing agents, because urine is normally acidic, and alkalizing agents may provide some quick relief, but it's not indicated in all cases, because in some antibiotics these alkalizing agent actually can reduce the efficacy of the antibiotic. Cranberry juice is very popular. Many times they start, and I've heard that cranberry juice has some actually antimicrobial qualities also. Antipyretics, patient can take paracetamol or some other analgesic, depending upon how much fever and how much pain patient have. Some kind of analgesic or antibiotic will have to be given. Follow up, how do we follow up? I think monitoring of symptom. Once treatment is started, we ask the patient to monitor the symptom. Within days, the dysuria should go away, fever should go away, pain should go away, and patient should start feeling normal. If that is not happening, that means infection is not responding. Then, as I said, I think it is recommended, unless it is just one simple case of urinary tract infection, if somebody has a predisposing condition or has recurrent infection, it is always a good habit to have the urine test at the end of antibiotic course, so that if pus cells are still present, then you may continue the antibiotic for another 5 days and repeat the same. Then one important lesson, that asymptomatic bacteriuria and pyuria also sometimes have to be left untreated. I'm not sure if this is others practice also, but I've seen people who have received antibiotics. They have no symptoms, but they have their urine is bacteria. This I've already said that these should not be treated, but sometimes we have to accept some pus cells also if they're not giving them any trouble and if they do not have any symptoms at all. So then recurrent infection, look for the cause. In women, there may not be any cause, but in men, if there is recurrent infection, there has to be a cause. BPH, a stone, or their abnormal sexual practices. Treat the underlying etiology if there is one, and then long-term and low-dose antibiotic therapy. This is another approach. Sometimes, particularly women, they have without any detectable underlying cause, they have this recurrent urinary tract infection. So sometimes we give them a low-dose antibiotic, not the therapeutic dose, the low dose, like 200 milligram of norfloxacin every day, or 100 milligram of nitrofurantoin every day for a long period. So idea is actually that kidneys are washed every day before the infection establishes. This is the strategy in some people who have recurrent infection, but there is no detectable underlying cause. Maybe vesico-ureteritic reflex, something like that. Complications, in most patients with infection, we expect a very prompt response, but in some cases, the infection could spread, it could become systemic, and there could be arthritis, there could be endocarditis, there could be osteomyelitis, there could be meningitis, and all kind of things are possible. And the most serious complication of urinary tract infection is urosepsis, because these are gram-negative bacteria. They have endotoxins in their cell wall. This could lead to endotoxic shock. Then, of course, not only you will be very particular about an effective intravenous good dose antibiotic, you will also have to concentrate on fluid therapy and many other things which are indicated for shock. That, of course, is beyond the scope of this lecture. We will cover shock in a separate lecture. Prognosis, routine infection, the prognosis is good, but in urosepsis, it could affect multiple organ. There could be multiple organ failure leading to death also. That luckily happens very rarely, and only in people who are otherwise very, very frail and have comorbidities. But simple urinary tract infection should be treated easily. Thank you very much. This has been Professor Aziz Rehman from Medurstand, and I look forward to see you in my other lectures, because now a series of lectures are coming for kidney and urinary tract. So I think if you join those, join me there, that will complete the module. Thank you very much, Professor Aziz Rehman.